Ritesh, hi, and thank you so much for joining me here on Faces of Digital Health to shine a light on the understanding of interoperability across India, the understanding of digital health transformation in the country with the highest population globally. You currently serve as the director at the Equitable Global Healthcare Foundation. In your previous roles, you were the director of digital health at the Health Systems Transformation Platform. You were the engagement manager and project director at IQVIA and several other companies and consultancies that gave you an in-depth understanding of the challenges and also the path towards success in healthcare IT and interoperability. I want to start with an understanding of the landscape in India for the listeners that do not know the country. I was there in 2017, and I remember how surprised I was that already then there was so much innovation and emphasis on convenience and last mile delivery. It was there where I first saw an offering for a phlebotomist to come to your home to draw your blood and actually then transfer that to the lab. I thought that was so forward thinking. Today, in the West, we've got a lot of providers that just send you a kit at home and then you can send that back to a lab so you don't have to go to a certified lab. There was also an active telemedicine and the use of iPads for patient management in the community at that time, which was very forward thinking 7, 8 years ago. So if you would have to describe the current state of healthcare digitalization in India, what stands out to you? What do you see as the big success in the country?
Thanks for inviting me for this session, and I'm truly honored to be here and very keen to discuss the work that we are doing in India. And to be honest, I'm very privileged that I got the opportunity to serve in some of these initiatives also directly. And apart from that, as on date also, we are bringing a lot of further innovations that can be infused with digital health in India. So before we formally start, so just want to share that how we are describing digital health in India. So basically, digital health started in India very late. Most of the initiatives at the government level started somewhere around 2012, and the primary focus was on reproductive and child health. So initially, Government of India has started a program that was by the name Mother and Child Health Program (MCH). But the problem was it was for the registration of the mother, and if they have a second pregnancy, their entire data was flushed by that time. So they, for ensuring the continuity of care, they started with a reproductive child health, wherein once registered into their reproductive cycle were being tracked up to the 49th year of age. So from 2012 to 2016, most of the focus were on these directions. Initially, the data is to be collected by the volunteers. So in every village at the population of say around 1000 to 1500 population, there was one voluntary worker that was supposed to go to the community, collect the data, and then supposed to enter these data. And she was also responsible for bringing the mother to the facility for antenatal care and postnatal care. Then we'll have the reproductive child health program. The next stage to this was because the data entry was happening at the facility, which was at the level of say 25,000 population. There is a primary health center, and the records were being shared to this primary healthcare center, and then the data entering was happening. So the idea was how we can actually ensure that data entry can also happen almost on real-time basis. So subsequently, there was a ANM online application that has been created, and the idea was there is a tablet that is being provided to auxiliary nursing midwife. So auxiliary nursing midwife is the is available at the sorry, sub-center in the village. So every village with a population of 5,000, and if you have two, three villages, the total sum of population is around 5,000. So there is a health and wellness center. It is also previously used to be known as sub-center. So sub-center or health and wellness center used to have one community health officer or one auxiliary nursing midwife. So they were providing the services, and then tablet were being extended to them so that they take care of the maternal and child health services. Subsequently, in 2016 to 18, there were prevalence of NCD. It is being reported that now more deaths are happening because of non-communicable disease. So then the focus shifted, and we have a vertical program that is supposed to take care of the non-communicable disease. So government initially focused on five diseases: the hypertension, diabetes, cervical cancer, oral cancer, and breast cancer. So screening camps were happening for these disease, and then based on the data were reported, and then they were analyzed, risk stratification was happening, and then based on that, service care delivery at higher level were provided. So then government started realizing that even in spite of all these initiatives, when the patient is actually going to the facility for treatment, like in case of RCH, when delivery is happening, the data is going to stay in the RCH portal itself, because still the patients are carrying the printed records or receipts that are being provided as part of service delivery. So no referral, e-referral is available. So then based on that, there are a lot of consultation happened. There is a national health policy that has been created. Then there is a e-consultation, and based on that, again, lot of paperwork happened. And then in 2020, when we have this COVID, we have the national health policy for telemedicine also. So telemedicine is being introduced. In between, we also have Ayushman Bharat Digital Mission that has broadly laid the foundation of how health record is going to be captured, how health data is supposed to be created, because most of the initiatives till that time were into vertical silos. So the entire program started for that from that, and since then there is no looking back. And many of our learnings are based on some Western world also. So as and when we progress, I am even going to compare the work that we are doing in India and how it is very, very different when it comes to the other international countries, what they are doing in healthcare. So even if we talk more about Ayushman Bharat Digital Mission, straight away, because we had some very good learnings from the unified public. Most of our learnings were from unified payment interface. So what UPI is all about? So suppose we are doing the financial transactions. So if I have a bank account and I have a mobile number, and my bank account is linked with my mobile number, I can make the transaction using the unified payment interface. So the idea was that if we can create the same mechanism, so that if I'm going to any health facility, there is a record that is being generated. I have a mobile account or mobile number through which I can give the consent for sharing or fetching of this record. And if someone else also want to have this information, can I share it based on my consent, this information? So UPI works on the same way. So on that same layer or same thought process, we have created a parallel structure in health. And for doing so, what we have done is, first thing is we need to identify the beneficiary very uniquely. And for this, we have created ABHA ID. So ABHA ID is basically a health account of that person, which is very unique to it. It is based on the KYC that has been used for creation of the ABHA ID. So every patient can only have one single ABHA ID. This is point number one. Point number two is there is a social identifier in India also, which is by the name Aadhaar. So Aadhaar is being used for creation of the ABHA ID. But ABHA ID is very different from Aadhaar. That is again something which is very common in India, because Government of India mandated that we can't use any social number because it prevails to the identity of the citizen, and we don't want any personal identifier of the patient to be used as a as a health identifier also, because it might feasible that health identifier being traveled from maybe when you are in lab, when you are going to any kind of pharmacy, when you are going to any facility, your same identifier should not be there. So on top of it, you have created one ABHA ID. Then the second challenge was that when you are going to any facility also, the facility should also be very uniquely identified. Any facility with same name, they should have different ID because the person that is serving there is different. So on top of it, we have created a registry for health care facility providers also. That is the second case. And then the third and the last important registry that was being created is the health provider registry. In case of health provider registry, the idea was that if any doctor, any nurse, any lab technician that is providing the services, they should have some kind of parallel registration also. Like in India, healthcare is a state subject. So every doctor is supposed to be registered in a state council, that he is registered and he can provide these services. But even for doing so, when they are providing these services, and then there are digital ways and means also, like telemedicine, because telemedicine doesn't exist when it comes to virtual region. So they are providing, but how we can identify that the doctor is real? They have actually passed out from some university. They are a registered provider. Similarly for nurse also. So they have registration into nursing council. Doctor has registration in medical council. So whether they are authentic one, so there also their Aadhaar registration, their degree validation by the college, everything is being there in the healthcare provider registry as well. So these are the building blocks of when we are talking about Ayushman Bharat Digital Mission.
Hmm. Can you explain a little bit the connection between the ABHA ID, which is, as you said, a unique 14-digit digital health ID for each individual, and ABDM, which is a government-led initiative to digitize Indians' infrastructure? So how do these two tie together, and what was the strategy when it comes to just creating this national interoperability and connectivity of data? I know that so ABHA ID really reminds me on the NHS patient identifier, so a unique number that patients in the UK have. And a lot of healthcare ID experts from the UK will tell you that the fact that patients have that unique identifier is of huge help when it comes to creating interoperability efforts.
Right. So, okay. So what happens is, uh, when any facility providing the services, generally what happens is, every time patient is coming to any facility, they are registering, and they are registering them against some central registration number or unique health ID, whatever. But it is very, very specific to that hospital only. But how we can ensure that any patient record that is being generated is being linked to your social security number or your Aadhaar number or your ABHA number. So that mechanism was initially not available. So from that perspective only, government has figured out that why not to create one Ayushman Bharat health account. So within, I really want to discuss what is the differential in ABHA also. So ABHA is basically very unique to you. I even initially also mentioned the same. And within the ABHA, this 14-digit number actually empowers you that within each health facility, you can be identified very uniquely. So the hospital is continuing to work with their central registration number, but what they have to do is they'll have to also enter my number, ABHA number, into their health record when they are generating any health record. And how this is going to be integrated with ABDM? So there are two mechanisms. One thing is any hospital that has to be that has to become the part of Ayushman Bharat Digital Mission. They have to have an application which is complying with the ABDM. So as on date, almost 350 applications are being registered by National Health Authority, and they are complying with the standards that were being laid. And if any of the facility is using that hospital, and the hospital also we need to be registered as health within the health facility registry. So from these two conditions, the health record that is being generated for any patient with ABHA ID, the electronic health record is made available when the patient is going to any other facility that is complying with ABDM. To simplify this, how this is happening and how this is very, very different, I'll give you one example. So suppose I am moving to hospital A that has ABDM application, and that is also being registered into the health facility registry. So when I am going there, the facility can create my ABHA if I don't have ABHA, and if I have ABHA, I just have to give my ABHA number. And then I'll have to have, maybe if I'm going for the OPD consultation, my prescription would be generated. And if I'm suppose going for some kind of surgery in IPD, so my discharge summary would be created.
Mm-hmm.
So when I am being discharged or when my prescription is being generated, there is a small set of information uh, through API is going to be connected with the HIECM. So HIECM is basically a health information exchange that has a CM, a consent manager. And sorry. And what this HICM does, that it doesn't uh, capture the information of the patient. This this HICM just store this information that against this ABHA ID, a health record is being generated in this facility. And when patient is going to hospital B, the hospital B also have some kind of ABDM compliant application. They are also registered in health facility registry. And the patient asks the doctor that I have been to hospital A and my health record is available. And when doctor from another application altogether try to fetch the record of the patient, he again hits to HIECM.
Mm-hmm.
The HICM, through its consent mechanism, give the information to the patient that hospital B want to fetch your record for this much of time, and this is the record what they are looking at. Is it okay that we'll share the record? So when the patient give the consent, the application HICM facilitates through whitelisting. Hospital B can connect with hospital A, fetch the data, and then this entire data is going to be displayed at hospital B in their HIS application. They can see, they can provide the consultation, and when their consultation is over, the entire data again is still stored in HIS of the application, and another record of the patient is being created. And now this HICM will update that another health record is being created. So
Mm-hmm.
this entire episodes of the patient in each hospital when they are ABDM visiting to any ABDM compliant hospital, these health records are being created.
Mm-hmm.
Uh, Another beauty of ABHA that I really like to highlight is, so I very specifically mentioned that ABHA ID, it's a 14-digit number. It is going to be the same, just like your mobile number. But like, at least in India, we can have several bank accounts. So like I have a bank account in Standard Chartered, I have a bank account in HSBC. So similarly, you might have accounts or you might have different kind of health records also, right? And if you want to share these health records into different buckets, you can do that. So suppose patient A who is getting the treatment from the hospital A for say TB, and when they are actually traveling to hospital B, they are taking care of the some non-communicable disease like hypertension and diabetes, and he don't want to disclose this also that he is suffering from TB because of any reason. So what they can do is, against the same ABHA number, they can also create ABHA address. And these ABHA address could be by default your ABHA number at the rate ABDM is your default ABHA address. But you can create, like my name is Ritesh. I can create my ABHA address as Ritesh at the rate ABDM. If suppose I want to specify that this is for say COVID, so Ritesh underscore COVID at the rate ABDM, so as to store specifically COVID related information. If suppose I want to store something related to NCD, I can have Ritesh underscore NCD, and all my NCD related information can be bucketed. And when I am sharing the information, then also rather than the information related to any specific disease, I can do that by sharing my consent. And the beauty of this entire system is the information exchange is not happening with ABHA number, it is happening with ABHA addresses.
Mm-hmm.
So every time you can differentiate it. This
Mm-hmm.
is first part. Second thing is even within the segment also you visited from past 10 years, but you want to share only last three records. So even that kind of consent within the consent mechanism, when you are getting the consent, these details are also available. You want to share last 1 month data, last 3 month data, last 1 year data, or all the data. So you'll have the consent. And you can also specify the duration for which you want to share. So suppose you have initiated the request and because of some reasons you'll not able to. So my data can be made available to your system maybe for 1 day, 3 day, so that you can use it, generate e-prescription also, like the way we are doing it in telemedicine, so that service delivery can happen.
Mm-hmm.
This is
According to data from July this year by the Confederation of the Indian Industry, roughly half of the population, or 700 million ABHA IDs, were created so far. So I just want to check that data. India has 1.5 billion people approximately. So what does that mean? So how would you assess the state of completeness, of IDs, of institutions that actually send the data in the system? Where is the country in that sense?
okay. So I'll just refresh because to best of my understanding and I believe till 21st of this month, 21st August 2025, we have more than 800 million of health records.
Mhm.
ABHA numbers that we can say so.
What does
But
that mean? Just before we continue, what does that mean for those that don't have the ID?
okay, I'm coming to that. So that means 700 million people are yet to be identified uniquely. Point number one. Point number two is if we look at this entire ABHA number or entire ABDM, this is a voluntary process. It is not regulatory. So you need not to, if you want to visit to any health facility, it doesn't mean you need to have ABHA. But if you have ABHA, you can obviously share your records more conveniently. The second thing is, if I'll compare this number straight away, 800 million ABHA number have been created. But if I look at the corresponding health records that have been created, it is somewhere around 710 million. And if you really want to check, there is a ABDM Insight dashboard that is there from where you can check all these data. ABDM Insight.
Mm-hmm.
So that means, and this is the idea that we have identified or we'll have more beneficiaries that have the ABHA number, but either they have not visited to any of the health facility till date, or second thing is they they have ABHA ID also. They are visiting to health facility also, but the facilities where they are visiting is not complying with the ABDM because ABDM is very clear. There are two limitations. One thing is you should be using the ABDM certified HMIS or application. Point number two, you should also be registered with ABDM as a health provider registry. So if these two conditions are not there, that means the facility where they are visiting is has some kind of challenges.
Mm-hmm.
And what this broadly signifies, and that is the crucial point. If we look at the adoption piece also, government has worked out a lot that how they can increase the adoption. So when we are talking about the national programs also, like I started with RCH application, reproductive and child health application, and the second application that I discussed was national NCD program, national non-communicable disease program. So if we look at, and if you can verify this also from ABDM Insight, that these two applications are the major contributor when it comes to the adoption of ABHA in rural sector. Then there are applications like e-hospital, CDAC, e-Shushruth, wherein when the patient is actually visiting to the facilities, their unique health ID is being created, uh, and their ABHA is being created. The other and most challenging pieces in many of the hospitals, ABHA is required for registration, right? And it is not a healthcare service delivery. However, uh, e-prescription or generation of prescription or discharge summary is something which is a health record. So many of the hospitals, be it public, be it private, they have adopted the registrations also, but they yet to adopt this application for clinical service delivery. So this is the significance. And my own understanding is if suppose we have almost 800 million beneficiaries that are registered with ABHA ID, and even if they are visiting once a quarter in every facility, the facility should be ABDM compliant, and at least in next 1 year, we should have at least 4 health record for each of the patient,
Mm-hmm.
the minimum set. So here we are lacking. So that means we have to work a lot on the penetration into private sector, into public sector. At the same time, we'll even have to ensure that the usage of HMIS should also needs to be extended.
Mm-hmm.
So there is one important thing. If you look at ABHA created by partner, if you slightly scroll up,
Mm-hmm.
yeah. So if we look at the first entity is PMJY, slightly scroll down.
Mm-hmm.
Uh, no, so sorry, slightly scroll up. ABDM by, yeah,
Aha, this
ABDM
here.
created by. So there is a PMJY. So PMJY is an insurance scheme. So in insurance scheme, yes, Government of India has mandated that you should have a ABHA number, then only you'll be considered for insurance scheme. So it is something which is mandatory and regulated scheme. So that is why it is happening. Second thing is the COVID piece. So when government went for the COVID vaccination piece, so they have created the unique health ID or ABHA ID of the patients. But during this piece, there was some Supreme Court ruling that without the consent of the patient, you cannot create ABHA ID. So that is why that program has stopped in between. The third thing, if we look at the government of Uttar Pradesh e-Kavach, so e-Kavach is again HMIS application, but they are only using this entire application for registration purpose. If we look at when it comes to the health record linked, so this number e-Kavach is not translating to the health record because it is only being used for the registration. And the fourth piece, what we discussed, National Non-Communicable Disease Program by Ministry of Health. The fifth is ABHA portal. ABHA portal is basically if you want to create something by your own. So this is the ABHA portal. So
Mm-hmm.
this is the way it is. Can you also look at the health record links? So you'll have on the same tab on the right side there is
This part.
yes, matlab if you can again scroll down slightly.
Mm-hmm.
In the same ABHA created by partner, if you look at the blue tab, health record link.
Uh, aha, yeah, this one.
Yes,
Okay.
yes. So now you can look at it. So non-communicable disease program is at top. second is PMJY. So herein the linkage is happening. So if we look at the UP piece, it is not there. It is shifted to
Mm-hmm.
fourth because more registrations are happening, but the records that are being generated has decreased considerably.
Right, right,
So
right,
this
right.
is this is the correlation, and this
Okay.
is the challenge, to be honest.
Mm-hmm. Okay. Um, Given that, all this data is now being linked and gathered, how much has all this information been used for population health and for any insights into population health? How much has that approach changed?
So again, I mentioned also like health being a state subject, and even if we look at the entire modus operandi is that at any point of time, the data is going to stay in the hospital itself, right? And within the ABDM, we are not going to store any kind of data. What information we are getting is number of ABHA ID that are being created, and again, the linked health record that has been generated. So from the state perspective, and there are a lot of applications that are being at the national level and state level. So state at their own, because they are the custodian of the data, so they can do lot of triangulation of this data. Because any patient, which is suppose initially they were any pregnant lady, suppose they'll during the pregnancy cycle they'll have gestational diabetes. So it was incidental only. So in most of the cases initially it was being stored within the RCH system only, but now because the systems are linked at the back end also, and in many of the cases states have created their unique interface at the front level also. So what is happening? They are just entering the information, but at the back end, the information is also being pushed to RCH application, to NCD application, and when now the patient is going to any linked health facility also, the entire health record of the patient is moving parallel. So this is something that is happening. But again, very specifically, the usage of the data when it comes to decision making is something which is yet to happen. And I'll give you again very scientific reason for that. So when it comes to disease surveillance is at least in India is being captured at three levels. One is at the primary healthcare level, wherein the auxiliary nursing midwife, the person at the community, is supposed to take care and supposed to fill one S form. S form is basically um, help the disease surveillance team to identify in any scenario if there are any cases that can't be confirmed. When it comes to disease surveillance program, there are basically three forms that are supposed to be captured, and capturing of these forms are also something which is happening at different level altogether. So first is the S form, which is supposed to be filled by the community worker, and they were just supposed to put the information like, have they seen any cases of malaria? Have they seen any cases of cough or something? And the second case is they were supposed to refer these kind of patients if they have more than 3 days of fever and fever with rashes. So there are almost 8 categories against which they are supposed to take the information. Then there is a P form, presumptive form, that is supposed to be filled by the doctor. So based on the conditions when the patient is coming to it, doctor presume that it may or may not have. So suppose if you have fever for more than 5 days, it could be malaria, dengue, or any other disease also. So then they were supposed to refer the patient to the laboratory. And then there is a L form that is supposed to be captured at the laboratory level. S, P, and L forms basically give you the prevalence of any kind of disease when it comes to India, and all these information are supposed to be reported in IDSP platform. It is Integrated Disease Surveillance Platform. Again, the other challenge is most of these informations are filled in primary healthcare piece, and when it comes to private healthcare, there is a schedule of 40 disease that was supposed to be mandated, and these are also supposed to be notified by the private player, but many of the private players are still not doing it. because the regulatory power lies with the state, and within the state there is a clinical establishment act that is supposed to take care of it. So that is the challenging piece. So when we are saying the usage of the electronic health data, so when we are actually deploying the unique health interface at the primary healthcare, and we'll have when once we'll have the HMIS at primary and secondary care piece, yes, it is solving a lot of purpose, and now the reporting is happening automatically, which was supposed to happen initially manually. And many of the times the information were not reported because either the data entry operator were not there or infrastructure not there. But because of this entire uh, ABDM digitalization, a lot of things are happening, and these are almost happening on real-time basis. So as and when doctor is raising anything, so S form is automatically being, P form is automatically being captured, and day end it is being shared with the IDSP. Similarly, all the laboratory tests, and within the laboratory also there are two parameters. So how many tests were conducted by the laboratory, and out of the conducted test, how many were found positive. So both these parameters were automatically being reported to IDSP platform. So yes, state is getting the information, but the process is taking bit of time because if we compare with West, they were using digital technologies well before time. They had the infrastructure, they have the money. But when it comes to India, we are living in a resource constrained environment. We have doctors that are not adequately trained, the lab technicians, the nursing staff, they are using the computer system for the first time. So there were a lot of challenges, but now they are migrating, and the migration is happening at a very faster pace.
Mm-hmm.
And again, for this, I really like to thank again the UPI, because during the COVID time and slightly before that also, people moved to digital payment gateways. And because of that, mobile was not a challenge for them in usage. And the second thing is the trinity that Government of India has created when it comes to Jan Dhan, basically a bank account, no frill bank account, to be honest, wherein they have opened the bank account for almost all the individuals that are even below the poverty line also, so that at least if any money is being given to them, it should be made directly into their bank account so as to remove or minimize the leakage. The second was the Aadhaar. Aadhaar basically identify the beneficiary uniquely, and from that Aadhaar, matlab, we'll look at if suppose you want to open any bank account, what you really need to do is the KYC, know your customer. And with KYC, Aadhaar based KYC, e-authorization is happening within seconds. So because when they have generated your Aadhaar, they have captured your photograph, they have captured your iris biometric and your photograph. So they can validate everything on the fly. The opening of account is going to take hardly a minute, and same with the mobile also. So if you want to have any mobile number now, onboarding of the customer is almost negligible because you can have the eKYC through Aadhaar. You can authenticate, the mobile number is can be linked, and all this process is seamless. So onboarding is very very uh, is taking lot of is not taking so much of effort, and in terms of cost it is minimal. So because of this trinity, when we actually move to digital healthcare also, so now people have access to mobile, they have access to smartphone. Even if we look at in terms of smartphone, we have almost 100 million, not 100 million, almost 1 billion smartphone as on date. And if we look at the penetration of mobile phone, both smartphone as well as bar phone, it is somewhere around 1.3 billion. So out of population of 1.5 billion, almost 1.3 billion is the total SIM numbers that are active as on date.
Yeah. That was one of the things that Sabine Kapasi mentioned in one of the previous episodes, that basically, even when you would have beggars on the street, they would ask you to basically transfer the money
Yes.
on their mobile phone. So, quite a digital transformation shift. So, we've discussed a lot the national infrastructure, the data gathering, and the importance of the digital identifier. What about innovation? What are you observing there in terms of startups? The Indian digital health market is forecast to reach 40 billion US dollars by 2030. Um, so how do you observe that, AI is coming into play? Are there any interesting approaches to integrating digital into care delivery and healthcare? Is there anything that you feel is worth mentioning? For example, I think one of the recent big news in digital health was that China opened a fully operated AI or robotic clinic. So that's definitely something that we haven't seen anywhere else. Where do you see that, India perhaps stands out in terms of innovation?
So basically, what is happening when it comes to India, the problem is slightly unique when even if I'll try to compare it with any other part of the world. So the first thing is, which is something which is very, very positive. If you want to collect the data or if you have any kind of model, AI model, you want to validate it, it is most convenient, most economical because the usage of data and seeking the consent of the patients for validating the model is cheapest when it comes to India. People are also open, government is also open, and even government is not only open, they are also providing a lot of infrastructure support also. So if suppose you are registering as a startup in India, you'll have lot of infrastructure support. You can link to any of the knowledge park. They can mentor you. You can have lot of access to cloud network as well. So if lot of free credits are available, if you want to use either Google or Azure or AWS, lot of free credits are even being provided by the government or by government supported entities. The third and other crucial part is linkages with the public sector also is also very common. So suppose I want to co-develop a model with any public health institute also, ensuring that the data or the personal identifier I'm not accessing, they are more than happy to do and validate this model.
Mm-hmm.
The second thing that I really like to highlight, because these are again contextual problem. AIMS Delhi, AIMS is the prestigious institute of tertiary care when it comes to government of India, and in India across also any patient, any disease, if it is not curable, you are being referred to AIMS. So AIMS Delhi has created a clinical decision support system, and it is supposed to take care of non-communicable disease. So what is happening in this entire system? So suppose you are an NCD patient and you are going to any primary healthcare provider, because the doctor at the primary healthcare level is not so equipped. But if you are giving them lot of information about what is your current details related to random blood sugar, your HbA1c level, your hypertension, whatever medications that you are taking, you are supposed to enter all the information. And clinical decision support system will give you that this is going to be your clinical protocol. This is going to be your daily regime. This is going to be your diet recommendation, lifestyle changes, whatever is desired. And the doctor just have to enter the information, and these are going to come as a recommendation. So doctor further can ask for more details or can have entire different kind of regime also. But the point is based on this tested model, because NCD has a lot of prevalence and people, because these are lifestyle disease, not keen to go to secondary and tertiary care to take treatments. And now government has also mandated that if prescriptions are being generated through telemedicine or from these kind of application, you can even take the medicine free of cost from these facility also. So just look at it, the kind of change we are trying to bring because of the prevalence of NCDs in India and how we can take care of the NCDs specifically in primary healthcare piece.
Mm-hmm.
Similarly, other two example I really like to give when it comes to reproductive and child health portal also. So uh, the health volunteer was supposed to provide antenatal and postnatal care, right? So when suppose for the during the postnatal care, they are going to the uh, uh, say to the household, and as part of the current regime, they are supposed to capture the image of the baby boy or baby girl, and from that image, their weight, height, etc. is automatically calculated using AI. So this is being created by Vadvani Foundation. So, and this is now being used by Government of India also in their RCH program. Just look at it just from the image, because otherwise carrying the weight, height is slightly difficult. But this is what they have done. Similarly, if we look at uh, TB is the disease that is causing almost uh, almost 3 lakh deaths in a year. And I believe 90% of the deaths that are happening in world uh, are happening in India only. So TB is a major cause. And the validation process is also simple. You just need to have a chest X-ray so as to identify whether the patient is suffering. But availability of the radiologist so as to check whether the patient has TB or not is difficult. So there is another entity by the name Cure AI. They have created this mechanism. You have to click the image of the X-ray. You'll have to share it into a central repository, and based on that, report is being generated with validation that whether the patient has TB or not. So just look at the cost saving that is happening because radiologists are not available. Clicking image from mobile is very easy. You just need to have a more than 2 megapixel camera. You can share it onto the system, and then within minutes you'll have the entire processing, etc., and everything. So usage of AI is almost happening in next level. And it is not within India also, even outside world also. If we look at, there are a lot of other software as a medical device applications are coming. So I'll give you very specific example also. So there are applications like CarePlex. So what they are doing is they are using the PPG sensor of mobile, and then they are capturing your hypertension and diabetes, lot of other parameters related to heart. Similarly, there are companies like Happy Tech. There are companies uh, like matlab lot of companies, lot of innovations are happening wherein the usage of mobile, and with the usage of mobile, you just like the health volunteers when they are going to the catchment area, rather than taking any device, they just take their mobile phone, they can capture the data, and this is giving you three broad validation. First thing is their electronic health record is not only being captured, it is automatically generated also, and then you'll have validation that this test really happens. The ASHA has actually met the patient, they have captured the data. Point number one. Point number two, in most of these kind of application, geofencing is there. So it is very clearly identified that in which part of geography or in which part of village you were, which road, where you were, and from where at what time you have captured the data. And third and most critical part is, as soon as the data is being captured, the patient also get the notification that your electronic health record has been created. And if it is some kind of a prescription, they can also access their prescription. So a lot of things in and around to this are happening. Other thing that I really like to share, if suppose in India we want to have the ultrasound, or if suppose we want to have any kind of surgery, almost in next 1 to 3 days we can plan everything. But when it comes to UK or US, even getting the appointment with the doctor is almost next to impossible. So this is the country wherein we don't have so much of doctors, so much of providers, so much of constraint, thanks to digital health technology that
Mm-hmm.
we're able to deliver such quality services.
Mm. Yeah. Higher efficiency.
Yes.
Where would you say that the biggest challenges are, or what are kind of the main milestones or projects that want to be finished in, say, the next 5 years?
So, actually, I am a great advocate when it comes to a regulatory kind of a body. Uh, like health in India, health is a state subject. When it comes to regulatory practices, you can't impose anything. Like if I could have been at the regulatory level, I must have mandated this that every patient should have ABHA ID. Every health facility should be registered. Every doctor should be registered into the system so that not only we can do the tracking, we can ensure that the quality services are provided. And because these are not mandated, there are no regulatory framework available as on date. Many of the hospitals are not onboarding into the system. So when it comes to milestone, I want 100% ABHA, 100% HPR, 100% HFR. The second thing that I really want to, because we have not yet touched upon, even when it comes to the entire ABHA system, there is a very, very unique frameworks or building blocks that we do have. One is National Health Claim Exchange, NHCX. So what NHCX precisely does when it comes to payer and provider arrangement, initially most of these things were happening in paper. And because government has also started PMJY, PMJY is the largest insurance, sorry, not insurance, assurance system. So government has started this assurance system. So they want that every uh, record when it is coming for approval should follow the same format so that they can increase the efficiency of the entire payer provider mechanism. And that is why they have created this National Health Claim Exchange. This is point number one. So even onboarding, the pilot has successfully been executed. Now the point is we have to onboard all the providers. We even have to ensure that all the providers and payer on board to this system. And second thing is they'll follow the same template. So this way we can at least in one of the sector, that is insurance, be able to make this mandatory. Point number one. Point number two, even within the system also there is one I mentioned about UPI. So in health sector also Government of India has created a unified health interface. So unified health interface, what it does is if you are coming from any of the application and you are hitting this UHI, you can connect to at the end any kind of hospital provider. So suppose you want to avail the telemedicine services. So rather than going to one specific provider, you can come to UHI. You can get a list of the telemedicine provider. If you want to go to lab, if you want to go to pharmacy, all the details are available within the UHI, and you can just hit this UHI. All the registries, repositories are available. You can, based on your choice, based on your location, based on your pricing preference, you can avail the services. So UHI is also bringing the adoption of ABDM more simpler, more beneficial for everyone.
When you say that all healthcare providers need to be kind of onboarded, let's put that in perspective. How many healthcare providers or hospitals approximately does India have, and what's the strategy for making sure that everybody goes through the
Okay.
adoption phase?
So in terms of health facility, I have some indicative numbers somewhere around uh, 2 million uh, health facilities we have, and out of this I believe zero point 0.4 matlab almost 20% have registered onto the system, right? But when it comes to the professional registry, almost zero point 0.7 million providers have onboarded. And when it comes to the total number is more than 4 million. So there also the adoption is somewhere around 17 to 18%. So it is very
Mm-hmm.
less. Uh, the other challenges when it comes to healthcare professional registry. So Professional can be anyone. If, like we talked about the doctors, the nurses, the lab technicians, the pharmacist. So these are something wherein they'll have a council that is registering. But lot of other also like if we are talking about the volunteers that are providing the services, the ASHA network, accredited social health activist. So in India, we have almost 1.4 million ASHAs. So they are coming from the non-regulated sector and they don't have any council or board. So when we are registering them, it's again a challenge otherwise. So the
Mm,
numbers may be huge. I don't have the exact number, but as on date, almost zero point 0.7 million uh, healthcare professionals are being registered.
mm. Yeah. It's definitely a huge project to get everybody under one roof. Ritesh, for today, I would like to thank you, for sharing all the insights and an understanding of how the Indian market looks like. Is there anything else that you would like to add in terms of the local innovation and providers? How open is the market for providers outside of India? Is it all locally built?
So, to be honest here, actually, and to okay, so this is something which is very distinct when it comes to India. If we are talking about UK and US market, most of the market is acquired by some limited companies. Epic, Cerner, they are the leader there, and their focus obviously is on is not on standards or quality of care, is on making the money. And lot of Indians are, as on date, also working for these companies, providing the services, providing the customization also. So nothing in favor, nothing in against. But if you look at Indian market, if suppose I am a startup, I want to start and want to provide the services. I just have to create the application. There is a ABDM sandbox on which I have to register. Generally, within 1.5 months, I can pass all the tests and then I can be registered and then I can provide the services. As a HMIS service provider or as a personal health record service provider, I'll have a key that when linked with the health facility key can create any kind of health record, can have the data, can push the data to HICM, can pull the data to HICM, something which is very simple. Registration, onboarding, everything is very simple. The second thing is we have not created any centralized kind of mechanism. From day one, the data that is being created in the health facility is going to stay there. So even as a user, if I'm creating any application, I don't have this burden that if I'll pull the data, where I'm going to store the data. Because end of the day, within the application, if something is created within, I can have very uh, easy kind of database like a flat files wherein I can use this data. And when I am supposed to exchange this data, then and only I can do the encryption and then share this to the other hospital based on the consent of the patient. So the cost of owning the application is very less. Cost of maintaining and running the application is very less. And again, it doesn't require so much of heavy registration or pricing or customization when it comes to Epic and Cerner. So our ownership cost of the HMIS is very less.
Mm,
That is
yeah,
also significant.
yeah, absolutely. Do you see any impact by any chance, on the whole software development with the rise of AI? There's a lot of automation that's happening. I wonder to which extent is, for example, AI impacting how much are companies from other countries using the Indian workforce as the back office? Do you see any impact there?
So I'll just answer this question in two parts. One thing is, uh, AI within the application also. I specifically like to mention, I don't know how I missed this. So, the biggest challenge of HMIS initially when it comes to India was the doctor is to patient ratio in any public health facility is 1 is to 100. So they were supposed to take care of almost 100 patients in a span of 4 to 6 hours. So that means the average transaction time between the patient and the provider was somewhere around 2 minutes. And in that 2 minutes, they were supposed to capture the clinical history. They were supposed to listen to the patient also. And at the same time, they'll have to generate the prescription. Thanks to the AI, now many of the HMIS applications, I like we are using one application for one of our project also, DRCFO application. DRCFO basically is doctor and CFO, the chief finance officer. So, the application is taking care of both the clinical part as well as the finance part. So, DRCFO application. So, what that application has does, it has used natural language processing. So, when the doctor is talking to the patients, complete transcript is happening. With the use of AI, the entire clinical history is being populated, the symptoms, the disease, and if any kind of diagnostics is desired, that is also being created. And in case if the medication registry is also linked, the system itself suggests the medication also. So by the time after the conversations, when the doctor is shifting to the laptop, almost within 15 to 30 second prescription is available. Doctor can do the customization, suggestion, etc. and everything, and then they can have the prescription generated. Point number one. Point number two, which is again something which can happen only in India, I believe. So the test is being prescribed, and in primary healthcare facilities, if we look at the machines that are available are not so very sophisticated. As on date, also, rapid test kits are being used. So now within the rapid test kits, generally you'll have the confirmation with yes and no. There are two markers, controlled marker, and then the positive result. So if these test kits are being placed under the high resolution cameras and being analyzed, you can even generate the record as a quantitative record. And this is also being performed and tested, and now the application is even CDSU. It is already FDA compliant, so now it is now being approved by CDSU also, the Government of India regulatory body for IVD. So they have also approved this device. So it is by the name, but the company name is Avalanche. So they have also done that. And just imagine how it can transform the primary healthcare when it comes to India. The second thing is uh, the use case that are being created in India and validated in India. Like I mentioned about CarePlex, they have tested the models in India on the population, and then based on the success, then they have filed for FDA, because modulation and creating the model and validation of the model is far more easier. Similarly, when it comes to the customization of the application also, so like as on date also, most of the software that are being created, even outside India for outside customers or within India also. And when Indian customers are asking for more, so the legacy version of the applications are now being sold to many part of the world at very, very reasonable prices, because we have moved to higher, we are asking for more because of the penetration of mobile,
Mm-hmm.
lesser data cost, and the customization and the AI is so much, is almost growing exponentially here. So the ask is more. Government is supporting. Initially, Government of India has run a program by the name DHIS, Digital Health Incentive Scheme. So if you're generating health records, you are being incentivized. So that kind of financial support was available within India. So in last 2 3 years, thanks to the leadership of National Health Authority and the vision of our Prime Minister, we have grown literally exponentially when it comes to digital health in India.
Mm, Yeah, it's definitely visible on the numbers that we've mentioned earlier and on the market potential that I mentioned. Definitely a country worth keeping an eye on. So, Ritesh, thank you so much again for the discussion today, and I hope we'll speak again in the future for an update.
Absolutely. It is my pleasure.